Hi, welcome back, CTO Demon channel friends. So today is the another co-curriculum talk on the global safety consensus recommendations for CTO PCI document. So now we come to something that's very core to CTO PCI. I mean, I guess if you were to talk about one complication that happens in CTO PCI, it would be perforation. That's where we see the most perforation. Of course, yes, we can get all the perforations in CTO PCI that you can also see in normal PCI. So we've structured this section into large vessel perforation, distal vessel perforation, and collateral channel perforation. Now, of course, collateral channel perforation shouldn't really happen in normal PCI unless you're very careless with your side branch wire or septal wire or something like that. So collateral channel perforation is maybe more dedicated CTO PCI perforation. Large vessel perforation and distal vessel perforation can happen in normal PCI. So first, let's talk about large vessel perforation. The first type of large vessel perforation we want to talk about is the knuckle wiring extra plaque stenting perforation. So when we do a knuckle wire, the wire is traveling down the extra plaque space, the subintimal space. And there's a big plaque volume, sometimes calcified, true lumen vessel stuff that's outside your stent. Which means if you stent the stent to the same size as the vessel, so you usually stent until the adventitia is full, there's going to be a big bulk on one side that has a chance of pushing and being pushed out through the adventitia, causing vessel rupture. And so usually our advice is if you know that you've gone extra plaque in that segment, don't be too aggressive with stenting. And certainly don't stent to the maximum size that you can measure on IVUS, because you're going to cause perforation. Now, it's a little bit more subtle than this. This is not in the paper, but it's a little bit more subtle than this. And if you want to think more carefully about this, this is the way you can think about it. So if you have a big chunk of plaque material and you have a slither of adventitia, okay? If the adventitia seems to be tied down quite tight, then you have to use quite a small stent. If you have a big chunk of tissue, but you have a big loop of adventitia, then you may be able to go bigger. So doing an IVUS is very helpful. If you IVUS and you find the extra plaque space is very crescentic, then in those cases, I'll be very careful not to go too big. But if you find that the adventitia is actually looped out, then maybe you can use sort of 3/4 size of the vessel kind of stenting. Now, the problem comes when you stent in these places and you perforate, because you're in the extra plaque space. And if you just put a cover stent, it's actually not going to anchor in the extra plaque space because the adventitia is very loose. Once you put a stent against the adventitia, once the stent expands, the adventitia expands further. And so it's going to keep leaking. So if we're going to cover stent an extra plaque rupture, what we need to do is we need to have the distal end of the stent inside the true lumen, intraplaque, and preferably 4 or 5 millimeters intraplaque, so that there's a sealing skirt. And the proximal end of the cover stent has also got to be intraplaque. So you've got to cover from distal true to proximal true. Of course, sometimes we're limited that we don't have that long a cover stent. And if you do an overlap cover stent inside the extra plaque space, you need a lot of overlap, because the only thing holding that second stent inside the first stent is the first stent's radial strength. Okay, so you need considerable overlap to seal it off. Best not to perforate extra plaque space. So the second thing is wire perforation. So when you're doing CTO, often the wire will go outside the vessel architecture. Now, when that happens, usually nothing bad happens. You pull it back and redirect the wire, everything's fine. The problem comes when you try to pass a balloon or microcatheter to follow that wire. So one principle is always be sure where the wire tip is before you pass the microcatheter. Avoid passing the microcatheter until you're sure your distal wire is in vessel architecture. If you're not sure of the vessel course, we always recommend knuckle wiring to remove vessel ambiguity. Now, knuckle wiring is fine. It's certainly better than using a sharp, stiff wire going through ambiguous vessel course. But we need to have one caution, is that sometimes knuckle wire runs down a side branch that we're not aware of. If you keep pushing a knuckle down a side branch, it can actually perforate the end of a side branch. So beware to check in multiple views that your knuckle is staying within the course of the main vessel and not going down a side branch. The other particular CTO large vessel perforation is reverse card. When we do reverse card, we very often use a balloon just to inflate. Now, you can judge a little bit the size of the reverse card from various things. The proximal vessel size gives you a clue, okay? The knuckle size can sometimes give you a clue, because if your knuckle in the subintimal, you can see how big the knuckle is. In our document, we came to a conclusion that the preferred method is to use IVUS. So if we're having difficulty doing small balloon reverse card and we want to upsize, it's better to IVUS and check the retrograde wire position and check the vessel size before we use a big balloon to do reverse card. Reverse card perforation is difficult because we don't have wire access yet. We just blow it up and we've got very little wire on the antegrade to manipulate a cover stent, and we're stenting into a subintimal or somewhere that we don't know. So it's not ideal to perforate a vessel when doing reverse card. If we have a perforation, of course, it's like any other perforation. For large vessel perforation, the first thing we need to do is to blow up balloon to stop it bleeding. If there is tamponade already, we need to do pericardial centesis, okay? We can use a cover stent to cover the large vessel perforation. Sometimes, if we've done a lot of dissection, the dissection flaps itself can act as the layer of cover, and just a normal stent can stent it through. So we need to judge a little bit how much dissection have we made, and sometimes if we made a lot of dissection, we can use the dissection flap. If you don't have a cover stent, which is not recommended, of course, but if you don't have a cover stent, what you sometimes can do is you can do a base earlier on and get a lot of dissection flaps down and use that to cover the perforation. Okay. Second topic, the distal vessel perforation. Now this usually is, you've crossed the CTO with a stiff wire and you're trying to cross a balloon or you're trying to cross the microcatheter and pushing back and forth, and that wire perforates. So we should always try to change to a workhorse wire as soon as possible. But of course, as soon as possible means getting a microcatheter across it so that you can change. So usually we get a stiff wire across the CTO, we control the position of the distal wire and try to get a microcatheter across. One little tips and hint, this is a CTO demon tips and hint, not in the original paper, is that it is better to improve your backup force rather than to force the microcatheter across. Because let's say you're in RCA CTO, you've got the distal wire in, let's say you use a guide X3 in the distal vessel, and you're pushing the microcatheter and your guiding is backing out. Now, as your guiding backs out, actually, the CTO wire actually also backs out, okay? And you're pushing the microcatheter. When you push the microcatheter, guiding backs out, the wire backs down. But when you release the microcatheter push, the wire jumps forward, and that's the time that you get a perforation. So, but if you stabilize the guide, if you put a side branch anchor balloon, and the guide doesn't move, when you push the microcatheter, first the microcatheter might get across, secondly, the wire moves back less. And so when you release, it moves forward less, and there's less chance of perforation. So it's always worth increasing the backup force if your microcatheter is struggling. Of course, you can say, why don't I switch to a balloon? Yes, a small balloon might be able to cross, but actually today's microcatheters are pretty good. And switching to a small balloon actually gives you little advantage if backup force is the problem. So try to go for backup force first, and then switch out to a balloon if that doesn't work. Because the backup force is going to stabilize the wire. Once you get the microcatheter across, of course, then you should take out the CTO wire and switch out for a workhorse wire, much less chance of distal perforation. Now, if you're unfortunate and have distal perforation, you should always try to deal with it. The problem with these distal wire perforations is that they tend to bleed very slowly. And the problem comes 2 hours later when the patient is already on the ward. And if you're doing an afternoon session, maybe it's already 9 p.m. and nobody's in the hospital, then that's a bad time to have tamponade. So if you have a distal perf, usually I would try to coil it or do fat embolization, do thrombin embolization, whatever you're used to stop the bleeding before you send them up, and rather than just to leave them. Okay, the final part is collateral perforation. So septal perforations are usually benign, and that's been the traditional teaching all these years. Septal perforations are okay, don't worry about it. It's not entirely true, because you will see there are certain case reports, small though they are, of problems. Now, I remember very early on, I was in a Japanese meeting, I think it was the CCT, and Dr. Saito, you know from the first video, see link in description below, he's my kind of first sensei, and he was doing a live case, and Dr. Kato was the chairman. And Dr. Saito caused the distal septal channel perf from LAD septal to PDA RCA CTO. And Dr. Kato says, don't worry about it, nothing bad's going to happen. So he's trying to keep calm and not worry about it. He took another injection to check through the guiding, not through microcatheter. And you can see literally on screen, this septal just, this little septal hematoma just grew a little bulb at the bottom, and that bulb just went bloop into the pericardium. And the patient went to tamponade, and there's a CPR, there's pericardiocentesis, and there was all hoo-ha in the whole audience. Now, I later learned from Dr. Saito, because we're good friends, that the patient's been on long-term steroids, and we put that case down to the fact that her myocardial tissue may be a bit weakened through long-term steroid use. I also had a case like that on a patient not on steroids. So probably it's not just the steroid, that septal hematoma can, especially the low septal hematomas, can perforate into the pericardium. So it's not entirely benign. The other thing that's been reported that everybody knows is not benign is the septal can grow a hematoma and cause outflow tract obstruction, what is known as dry tamponade. Also reported is septal hematomas that causes arrhythmia. Now, dry tamponade is very bad. If you look at the case reports in the literature with dry tamponade, most of the patients end up dying. And the only patients that are reported survive are the cases where they've done fenestration from the septal hematoma into the RV or the LV. RV is preferable, of course. And based on this set of case reports and the experience of the collective 147 CTO operators who wrote this paper, we came to the recommendation that if a large septal hematoma develops, and we leave large vague as it is, we should try to fenestrate into the RV. That, by doing that, it is putting a microcatheter down into the septal hematoma and then using a high penetration force wire to push it into the RV, and then pushing the microcatheter across and switching out a workhorse wire, and then putting a balloon and ballooning it into the RV to decompress the septal hematoma. Most of the cases of dry tamponade that causes severe hypotension that have survived had this done. So this probably is the best outcome that you can get if you have a large septal hematoma. So that's the recommendation from the paper. Septal collaterals perforation is basically, those are the problems. Dry tamponade, very low septal sometimes can get tamponade, and sometimes ventricular arrhythmia. For epicardial perforations, then obviously there's tamponade, and we can tap it, and we can coil the epicardial collaterals. One particular group worth paying attention to, and we mentioned this particularly in the paper, is the post-CABG patients. These patients, sometimes they have a perforation and they don't get general tamponade, they get a local tamponade that can compress the cardiac chamber. And these are very difficult to tap, and usually requires either CT guided tapping or actually a reopening of the chest to get rid of the blood from that segment of the pericardium. The other type of collateral channel perforation is the antegrade collateral channel. Sometimes there's these antegrade bridging collaterals, and sometimes people mistake these for residual channels inside the CTO and cross them. If you cross these and you balloon it, they're a massive perforation, because these are actually collateral channels sitting on the wall of the vessel, not inside the vessel. And this is to be, so we have to look at this carefully to make sure that if we think it's a residual channel, that it's not a collateral channel. So the other type of perforation that happens is the collateral channel injury. And the most common way this happens is the cheese cutting effect. So if we have a bare wire on a channel and we put pressure on that wire by pulling it, it's going to cheese cut into the channel and perforate. Both epicardial and septal channels can perforate. Now these perforations are big perforations because the end of that cheese cutting line is actually in the PDA. And so you get a PDA perf, and these go into tamponade. It doesn't just form a septal hematoma usually. So it's always important to protect all epicardial and septal collateral channels with a microcatheter when we're pulling or pushing on the retrograde channel. And even when we're doing the CTO with an external wire, we always try to keep the retrograde microcatheter covering the whole channel and make sure it does all the time. We had a little section on persistent staining, and this is just for the sort of beginner operator, because sometimes we see a lot of contrast and we worry a lot. But actually, if you see persistent staining, that's a good sign, because it means it's not going anywhere. And if you do see persistent staining and your echo shows no fluid in the pericardium, you're probably not going to get tamponade. So persistent staining is actually good. If the contrast flows away, it's either in the pericardium or it's in a chamber. Chamber is good, pericardium is bad. Now there is one particular problem, and this is the RV marginal, and I suppose it can happen in lateral wall too. But RV marginal is particularly prone to it. The RV marginal purse very often form a hematoma in the anterior wall, and this can cause a persistent staining. But this hematoma can build up gradually and actually perforate later. So I've had a couple of cases like this. You send out the ward and 2 hours later they suddenly go and tamponade because the RV marginal, the anterior wall hematoma, is perforated, even if you seal it off. So those patients are worth watching more carefully. The other issue we talk about is intact pericardium, because the intact pericardium is good, but in post-CABG patients is quite often loculated. And so if we have a perforation in those cases, sometimes you don't see a pericardial effusion, but they can still have hemodynamic collapse because of compression over chamber due to the pressure from one local site. These are very difficult to drain and usually require open surgery. So how do we prevent especially collateral channel perforation? There are several tips and tricks. Number one is when we do selective injection, the traditional method of doing selective injection through a microcatheter is to suck back and make sure there's blood back bleeding. That's a good practice, I think, because if there's blood back bleeding, you're not jammed against the wall and you're not poking outside the channel. So if you do any selective injection in any collateral channel, I would highly recommend to check black bleeding. If there isn't, come back a little bit and do it again. Don't surf epicardial collaterals. I think this is agreed upon now by almost all retrograde operators around the world that we shouldn't use surfing technique for epicardials. We should direct the wire and follow the selective injection. If we have a perforation, obviously the first thing to do is to put suction onto microcatheter, because usually the channels are small enough to be at least tamponaded by suction. And while we have suction, we can prepare to call and prepare whatever we need to stop the bleeding. The removal of retrograde gear after externalization is very important. I have a separate video on that. The link is in the description below. Please look at that because that's a little bit too detailed to put into this video. Actually, that other talk with that very complex table was part of the original draft of the paper, but we found that many journals, the editors couldn't understand it or struggled with it. And so we decided to take it out in the end, and it's become one video. The use of a contrast echo is useful. Sometimes if we can't identify whether there's a contrast echo is going to help us. Protamine. What is the role of protamine? On the whole now, I think all of us agree that protamine is not good until the whole thing is finished. So if you still have gear in the coronary and you put protamine, you risk thrombosis in the coronary, and we've all seen this. So it's better to keep giving heparin until you finish everything. Then you can reverse, all the gear is out, then you can reverse with protamine. So that really is a video summary of that very complex section in the paper under perforation. Of course, we all wish we don't have perforations when we do CTO PCI, but it's best to be prepared. Chance favors the prepared mind, as they say. So I hope you don't have any perforations, but if you do, I hope this video helps you. And if you like the video, please press the like button, and I look forward to future videos. And if you want to catch them, please press the subscribe button. I'll see you next time, my friends.